कुलकर्णी सर म्यूट करता का?
हो हो हो.
पटवर्धन सरांचं का नाही बघायला पाहिजे.
सर पटवर्धन सर आहे तिथे, फक्त त्यांना अनम्यूट करावं लागेल.
सर यू आर देअर, पटवर्धन सर. पटवर्धन सर. सर ऐकू येत नाही पटवर्धन सर.
हा, ऐकू येत आहे.
हा, या यू आर देअर. सो आय थिंक we'll start now. So very warm good morning to all the pediatricians and our friends attending this webinar today. As we are all aware, we are in the webinar era now because of COVID, and we don't know when we'll be live physically. So for this month, we have planned a webinar on the allied specialties, that is the pediatric orthopedics and the pediatric surgical branches. And we have a very eminent faculty to take us through the important topics in these areas. And I will hand over the mic to Dr. Manisha now to start the proceedings and after introduction of the faculties. Dr. Manisha, please.
Good morning, everyone. A very warm welcome to all the delegates and our panelists and faculty. A warm welcome to this webinar on orthopedic and pediatric surgery, pediatric orthopedic and pediatric surgery. So we'll start today's session. We have three eminent pediatric orthopedic surgeons from Pune. First, I will introduce Dr. Sandeep Patwardhan, who is a very well-known figure in pediatrics.
Just give me a second, ma'am. I'll just share the screen.
Yeah.
Can you see?
Okay. Yes.
Yeah,
yes.
you can continue.
Okay. So, Dr. Sandeep Patwardhan, warm welcome to you. A very well-known figure in pediatric orthopedics in Pune. Is a pediatric orthopedic surgeon specialist at Sancheti Institute of Orthopedics and Rehabilitation, and also a visiting pediatric orthopedic consultant at Bharati Vidyapit Medical College and Hospital, Pune. Next is Dr. Ashish Ranade, who is a pediatric orthopedic surgeon at Dinanath Mangeshkar Hospital, Surya Mother and Care Hospital, Pune, a visiting pediatric orthopedic faculty at Bharati Vidyapit, Pune, who has presented numerous international national papers, has more than 25 publications, and serves as a reviewer for several journals and is the editorial board member for 3 journals in pediatric orthopedics. And our third faculty today morning is Dr. Samir Desai, who is a pediatric orthopedic surgeon at KEM Hospital, Pune, and also at Jahangir Hospital, Ruby Hospital, Unique Children Hospital, Inamdar Hospital at Pune. He has a special interest in clubfoot, pediatric trauma, and cerebral palsy. And he is a social initiative in Clubfoot Medical Foundation and has developed a website for Divyang marriages. So very warm welcome to all our faculties, and I request Dr. Sandeep Patwardhan to start his lecture today.
Thank you, Manisha. Can you hear me? Am I audible?
Yes, you are audible.
All right. So at the outset, let me thank Dr. Sanjay Nathu, Dr. Kulkarni, and Manisha for inviting me to this webinar and sharing some information about deformities in children. So I guess my screen is visible to you.
Yes, it is visible.
Okay. All right. So when you talk of deformities, the most obvious thing is congenital deformities, but I will not be talking too much about that initially. I will talk to you about crooked limbs. The commonest problems that as a pediatrician you will see in your OPD are bow leg, knock knees, in-toe gait, out-toe gait, flat foot, and something that is now being identified as MMS, that is miserable malalignment syndrome. And what are the answers that you seek? You want to know what is normal. You want to know how to evaluate it. You want to know whether it needs treatment. Do braces really work? When do we offer surgery? So we have to start with understanding the natural development and alignment of the limb in a growing child. All of you know that initially when the child is born, we have a varus alignment, as you can see here, of about 20 degrees. And by about 1.5 to 2 years of age, that will come down and it will become near normal or neutral. I would say not normal, neutral by about 18 months to 2 years of age, somewhere here. And then from 2 years to 5 years, we are into a valgus phase, which can go right up to 10 degrees to 15 degrees of valgus. And then it starts coming back to normal by about 5 years or 6 years and stabilizes between 7 and 13 years of age. So what you have to realize is that this is the normal spectrum. 95% of the children will lie between this spectrum, and this is the normal development of the tibiofibular angle. This is a very important paper because it talks of the normal development in healthy Indian children, a study from Sion Hospital, Mumbai. And what they showed was that it is not important to take X-rays every time. Clinical methods of measuring the knee angles are acceptable and reproducible. And the advantage being it is cheap and doesn't need any radiation. Okay, so what you need to know is fixed bony points, which is the intercondylar distance and the intermalleolar distance, which we will highlight soon. Palpating those landmarks and measuring it in your OPD with a simple measure tape will tell you whether the child has a physiological bow leg or a knock knee or it's pathological, and whether further investigation. Know what is normal, then we can work on what is abnormal. So this is the normal alignment that you are able to see here. You mark the patella, you can draw draw the center of the ankle. So just simple clinical measurement. If you have a goniometer, you can use the goniometer, but that is also not required. What you need is just a tape. So measure the intermalleolar distance, and that will tell you what is correct and what is not correct. What we have seen is that in Indian children, by 6 to 7 years, the valgus, which is physiological of about 5 degrees, is stabilized. So anything more than 5 to 7 degrees after about 7 to 8 years definitely warrants observation. I won't say prevention, I'll say observation. It is out of the normalcy. And what is happening in our country is exactly what happened in the Western world. Couch potatoes and obesity. So childhood obesity is really changing the weight bearing the knee and more and more deformities. So you know that obesity, medical conditions, what it causes, but I'll just highlight what it causes in orthopedics. We see a lot of children with slipped capital femoral epiphysis nowadays. We see adolescent age group tibia vara, which is Blount's. We see a lot of genu valgum, which is associated with obesity, especially in girls. We see miserable malalignment syndrome, and we are seeing a lot of stress fractures because these children also are in the sporting age group. So let's talk of bow legs. There are only 4 causes of bow legs that we see. One is rickets, second is Blount's, third is dysplasia, and fourth is physiological torsion. So we'll go through all of them. So look at these X-rays. The first X-ray on the left side is actually a physiological bow leg. The second X-ray in between is showing you epiphyseal changes here, which is suggestive of rickets. And the third X-ray is showing you unilateral bow leg with spiking or beaking of the proximal tibia. Now this could be Blount's disease. So what you should understand when you take X-rays, they should be in correct rotation, because a mal-rotated X-ray will give rise to an appearance of a spike. The ricket is pretty obvious, and you need some blood test to confirm that, where you have actual epiphyseal irregularity. And remember, blount is usually unilateral, whereas both the other conditions are bilateral. You that more about Blount's disease. If you are suspecting rickets, obviously, then you will get the alkaline phosphatase. And if it is raised, treat it with vitamin D supplements and calcium supplements. And in 6 weeks, all the radiological changes should reverse. If they do not reverse after 6 weeks, then you are justified in getting additional tests done to rule out renal rickets, such as urine pH and an arterial blood gas. So the first step is nutritional rickets. So you treat rickets, the changes go away, alkaline phosphatase come back to normal, continue observing them in the normal growth pattern. By about 6 to 7 years, the deformity will disappear. If it does not, we can help you. But 99 out of 100, they will resolve on their own. And what are the changes of rickets that have to go away? That cupping which you see has to become completely straightened out like that. So you see complete resolution of the cupping in the right X-ray. And that is the correction that you will see in some time of the deformity. Torsion is the second problem. So when you have a tibial torsion or a femoral torsion, that gives rise to a spurious appearance of bow leg. Okay, and you should know how to evaluate it. So what you need to do is, in torsion, these are the same X-rays of the same child. Okay, in one you have it in neutral rotation, one is not in the neutral rotation. So you can see double cortex on this side, which highlights torsion in the distal tibia. If it is not taken in the correct angle, misreporting can happen. Don't believe the radiologist reports. Look at the child, look at the torsional profile, and this is how you should do it. Put the child on the tummy and look from top. Normally, the foot should be pointing about 15 degrees outwards. In this child, you can see the left is pointing significantly inwards. Even the right is pointing inwards. So this is called thigh foot angle. And the normal, as I said, is about 15 degree outwards. If you see it's looking inwards, then you're looking at internal tibial torsion, which exaggerates with a slight bow leg and makes you feel that the child has a grotesque deformity, whereas torsion is the reason for all of that. So physiological bowing associated with torsion over a period of time is going to spontaneously improve. In about 2 years, you should see it corrected. If you find that the intermalleolar or intercondylar distance is more than 10 centimeters at 4 years, then it is pathological. Okay, we will come to this again. Now, this is definitely abnormal. A significant torsion with a significant bowing, which requires treatment. Now, this is also called an XO deformity, in the sense when you make the thighs parallel, the legs cross like an X. And when they are kept apart, it looks like the legs are in an O position. Earlier days, we used to do small osteotomies and fix it and give plasters. We no longer do that today. Today, we are using what is called as guided growth, using 8 plates. So we have a specialized tool, which is very simple, minimally invasive, and we put in small clips on the growing end, and we cause or create a teether so that the opposite half keeps on growing and we can get deformity corrected out. In Blount's, how do you know whether it is physiological or Blount's? There is an angle described, which is called metadiaphyseal angle. Okay, so this can be femoral or tibial, but this is proximal tibia is we usually measure metaphyseal angle. So MD angle between 11 to 13 can be pre-Blount. More than 13 is definitely Blount's disease. See, in physiological bowing, you do the tibial metaphyseal diaphyseal angle. If it improves by 3 degrees per group, there will be no change in this angle. It continues to be bad. So if the TMDA improves 3 degrees, Blount bilateral, eventually corrected with age only, because this was not exceeding the required parameter. And this is an example of a Blount disease. And very early Blounts, you can get an MRI to see the underdeveloped cartilage, as you can see here. This
So your connection is breaking. The connection is breaking. So can you
Sorry?
just stop your video?
ऑडिओ नेट अवेलेबल नहीं होते.
Okay,
You
can you
just
hear
stop
me
the
now?
video. Yeah, better. Yes, sir.
हा.
Okay, what
मध्ये मध्ये ना आवाज ब्रेक होतोय कारण संदीप.
okay, I'll just stop. Can you just switch off my video? At your end, if you just switch off my video, probably it will be, okay. So,
Okay, you
are we
continue.
okay now?
If there is any problem, we'll tell you.
So this is a classical Blount's disease, and this disease we have
संदीप अजूनही डिस्टर्बन्स आहे. ऑडिओला डिस्टर्बन्स आहे.
So what do you want me to do?
Bandwidth problem.
Okay. Actually, I'm connected to a full signal is there.
It's
My
good
connection
now.
is also quite
आता
okay.
व्यवस्थित आहे, sir. You can
आता
continue.
येतंय.
It's good?
Yeah. Continue.
Okay. Just give me a moment. Let me get back to the screen. Can you see the screen? Hello, can you see the screen?
No, sir, not yet.
नाही दिसत आहे.
So I'll have to share again now. I think. Can you see?
हा,
Yes,
आता
sir.
चालू झालंय शेअरिंग. Now we can see.
All right, so I'll go to the screen share. Yeah. Okay, you can see that, right?
Yes,
Yes,
we
sir.
can.
Okay.
You can go.
Yeah.
Yes.
So this is growth modulation, and this is how you correct a deformity in very early or pre-Blount. If you pick it up very early, growth modulation can help. Whereas if it is late Blounts, where there is a fascial depression, you will need an osteotomy. So this is an example where we had to do a osteotomy to correct the rotation as well as do a growth modulation. So this is what I call a staple plate. So sometimes 8 plate may not work, and we may need to do this staple plate with a osteotomy. So this is correction of that child post surgery, and after the alignment is corrected, you will see that the medial condyle starts ossifying. This is a longer follow-up, and this is a 5-year follow-up when the plates have been removed and the leg now is well aligned. Sometimes patients come really late. This is adolescent Blount, very bad looking tibia, you can see that. And then they have to undergo really major corrective osteotomies to get the leg straightened out, what we call as a double oblique osteotomy with hemiplateau elevation. So that is the correction for that child from pre-op to post-op. But you can avoid all this surgery provided you pick it up pretty early. The third thing that I said for bone is dysplasia. So when you suspect rickets but child is not responding, or your vitamin D levels have come normal, or your alkaline phosphatase is normal, then the irregularity in the physis could be genetic, which means dysplasia, and you should take X-ray of the hip and spine. So that will tell you that, okay, I'm looking at a multi-epiphyseal dysplasia or a genetic condition like achondroplasia, where we can again help with some growth modulation. So that is how we treat when deformity is part of dysplasia. But dysplasias will need prolonged treatment, and sometimes the physis does not respond as well as it does in rickets. So let's move on from bow legs to knock knees. And again, knock knees are 3 common types you will see in your practice. One is normal physiological, which I already told you, till 6 to 7 years. Second, because of rickets. And third, idiopathic. In our country, we see obesity as the single most important reason why legs go into a valgoid. If you are suspecting pathology, they will come with pain, stiffness, asymmetry, short stature, limb-length discrepancy, or laxity. And then you are justified in getting a skeletal survey, the metabolic profile, and some hormonal workup. What are the common causes of genu valgum? Renal osteodystrophy. So all your patients who have nephrotic syndrome or CKD cases who are on dialysis or need transplant, we see a lot of them coming with deformities of valgus. You can have metaphyseal dysplasia. You can have multiple exostosis. Genu valgum is also very common in Down syndrome, in storage disorder, and rare condition called Ellis-Van Creveld syndrome. If it is unilateral, it can be because of trauma, infection, or previous surgery, and sometimes after a fracture. That's called Cosen's phenomenon. I'll just show you that. So how do you monitor? As I said, clinical monitoring. Measure the intermalleolar distance. If it exceeds 10 centimeters, it's pathological and it's not likely to correct with time. Bracing does not have much role. Brace inserts and bars have not shown to be of any value, and you need to treat the metabolic cause, if any. And again, we have two tools for correction: growth modulation and osteotomy. So an example of a post-rachitic genu valgum, obviously you can see deformity is not acceptable, and you put the growth modulation clips and the leg straightens out over a period of time. In 12 months, the leg is straightened out. In Down syndrome, again, genu valgum, and then you put the clips and it straightens out. So we can do a lot of wonders with simple small surgery. Unilateral proximal tibial valgus because of multiple hereditary exostosis, again, growth modulation, and that has straightened out. Renal rickets, you can have a multi-apical deformity here around the knee in the growth plate and in the diaphysis in procurvatum, you can see there. So we may need to do an additional osteotomy in the diaphysis and get that deformity corrected. So that is an example. Dysplasia, modulation and tibial derotation osteotomy. When can we not do the growth modulation? When the child is nearing maturity, starts menstruating in girls, X-ray shows that the olecranon epiphysis has fused. Then we don't have a choice of growth modulation. We must do an osteotomy. And that involves cutting the bone and putting a plate and allowing to heal in the correct position. So that is an example of
Again,
that is
there
how the
is
deformity is corrected. Yeah, just
there
give
is
it
some
time.
audio
Just give,
disturbance, huh?
yeah, just give it time. I think it's the bandwidth problem. Can you hear me now?
Yeah. Now we can.
Yeah. So long sentences, I think it breaks in between. All right. So this is now showing you that the deformity is corrected after an osteotomy. But we can avoid this if there is early referral for deformity, and you shouldn't wait till it becomes this bad, where we have to do really major surgery. Okay, again, a Downs with really bad knees, which have been corrected. This is Ellis-Van Creveld syndrome, polydactyly, bad teeth, and ghastly deformity. Neglected for so long, this could have been managed very well if she had come early with growth modulation. But then I had to do multi-level osteotomies and get that corrected. And in spite of which, the joint is never going to be perfect, though the deformity is gone. Okay, this is a 4-year follow-up, but she's likely to end up with arthritis. The last part is in-toe and out-toe gait. So torsional problems and miserable malalignment. So this is commonly seen with laxity syndromes. You check for the laxity, the Baton's criteria, extension of the elbow, flexible flat foot, and you see W sitters walking with gross in-toe gait. So this is the simple test which shows you that excessive internal rotation and less of external rotation. Sometimes they have a foot deformity of metatarsus adductus, which makes you wonder whether it is in-toe gaits. So look at each component: the foot, the thigh, and the knee. Out-toe gait, again, in femoral retroversion. Reverse of anteversion is retroversion. You will get out-toe if you have slip capital femoral epiphysis, which you should rule out, and a flat foot, which we will come to. So if you have an obese child who has a mild limp with an out-toe gait and a small injury, please remember that he may have slip capital femoral epiphysis, because that is the only condition which needs intervention. All others have to be just observed and nothing needs to be done. So a bad out-toe, which is unilateral, commonly sometimes bilateral, will need surgery to correct by an osteotomy through the capital femoral epiphysis. What about flat foot? Another common condition in your OPD is flat foot. The commonest one is going to be benign. Symptomatic ones are the ones which need treatment, which we will come to: coalitions, neurological or congenital. So what are the types of flat foot? The common one is the mobile flat foot, which is physiological with hypermobility syndrome in obese children and rarely because of paralysis of tip post. The second is the rigid flat foot. So rigid flat foot is when there is tarsal coalition, which means small bones of the foot are born. They are born with fused bones and they need separation. So the simple test that you need to do in your OPD is called Jack test. You dorsiflex the great toe and you will see the arch reappear, or make them walk on their toes, the arch reappears. This is a flexible physiological flat foot. So when they walk with weight bearing, it looks like this. But when they walk on their toes, you will see the arch. This is flexible, painless, and nothing needs to be done. Check the mobility of the subtalar joint. If it is flexible, we have a mobile subtalar joint, and this is not a serious problem. Mid-tarsal joint mobility also you should check. So if it is painless, which is 99% of the time, nothing needs to be done. Rigid flat feet is happening only in 1% times, and they may have some treatment which is required. Suppose you have a flat foot, the parents will always ask you, what will happen? What are the consequences of a flat foot? The only consequence in the early age is distortion and wear out of shoes. The child does not have much of a problem. So you will get shoes which wear out on the inside like this, and most of the times they are asymptomatic. It is a problem of the parental concern rather than the child coming to you saying there is pain or deformity. The parents get them to you because they feel that flat foot is something bad. Sometimes, very rarely, in the older age, you can get foot strain or pain. Does flat foot become painful? Now look at this study from Army, 3,600 Canadian Army recruits. This is published data. Flat foot does not cause disability. Two Indian studies, both by Dr. Benjamin Joseph, 1992 and 95, 2,300 children as well as adults with flat feet. And his conclusion was they are generally asymptomatic and does not need treatment. If you do need treatment, the commonest treatment is no treatment, counseling of the parents and send them home. Shoe modification, shoe inserts. A lot of people are given these or prescribed these, and that creates extreme anxiety in parents. And the last option is surgery. So the popular treatment is arch support and exercise with the silicone gel pad. And special shoes is what people ask for. But is there some evidence to it? This paper published by Dennis Wenger did a study with a 3-year follow-up. They had 4 treatment groups. A control group where they did nothing. They gave corrective shoe to some people, arch support to some people, and the UCBL insert in shoe for some people. And what was their result? There is no difference between control group or treated group. What does that tell you? Asymptomatic, flexible, idiopathic flat feet do not need treatment. They do not need shoes. They do not need any wedges because they are part and parcel of a physiological variation because of laxity, and they don't really need treatment. Only those who are painful may benefit with arch supports. Treatment does not produce any better results. What is the role of surgery? Surgery is required only when it's painful, congenital, or neurological. So this is an example of a coalition. You can see that the navicular is to the calcaneum, and I'll just show you in a video. This is the normal leg. Look at the subtalar motion on the left side and on the right side. On the right side, you can see it is stiff. There is no motion, and when the child runs and plays, he gets pain. So painful flat foot, which is unilateral, this is the surgery. We have to excise the bar which was connecting the calcaneum to the navicular. So the bar is excised, and after excision of the bar, you will see significant motion. So there is an option for surgery for painful, stiff, flat feet. This is what you should remember. Okay, the second is vertical talus. Sometimes you have congenital flat foot. This is vertical talus, which will need correction surgically to restore the arches. Sometimes in CP, we need to do correction of flat foot for a stable base of gait. So that is called arthroeresis. We put a bone plug to prevent a flat foot. So I'll show you an example how we use this bone plug. Now this is a spastic child. Look at his feet when he walks. You can see that there is a secondary flat foot because of a midfoot break. And the hind foot is off the ground. Now this creates an unstable situation. Here we do the arthroeresis, and post surgery, you can find that his foot is well corrected, stable on gait, and his ability to walk improves significantly. So deformity correction and giving stability for spastic flat foot. Rarely in adolescent age group, if you have a bad flat foot which is painful, we can do calcaneal osteotomy, correct the flat foot, or a triple C osteotomy and correct flat foot from this bad deformity to a more reasonably looking foot with good surgery. Miserable malalignment is a combination of torsion and flat foot. And but it is becoming. And finally, the deformities of defects like congenital knee dislocation, club foot, hemimelia, or arthrogryposis obviously will need intervention. They are not physiological. We will need to do plasters or surgery to correct these. Foot is common as that you will see. Plaster treatment started within the first week of life will give them excellent results with a long follow-up. Thank you very much for your kind attention and stay safe in this COVID era.
Thank you so much, Dr. Sandeep Patwardhan. That was an excellent presentation, giving us very simple techniques to identify some of the most common pediatric orthopedic problems that we see in our OPD, and some simple tests to diagnose which is pathological and which is not. We will be taking all the question answers will be taken at the end of this pediatric orthopedic session. So I request Dr. Patwardhan to be with us for some more time. And
yeah, you can just start my video. The host cancelled it.
Yeah, I request all the delegates to put up their questions in the chat box so that we can take up all the questions later. So let's now move on to our next session, which is by Dr. Samir Desai. Is Dr. Desai there with us?
Dr. Ashish will be taking this session.
Yes.
Okay. Okay. So next session is by Dr. Ashish Ranade on bone and joint infections. So I request Dr. Ranade to please start the next lecture.
Good morning. Am I audible?
Yes, you are.
It's a pleasure to be here. I would like to thank IAP Pune, Dr. Sanjay, Dr. Manisha, and Dr. Kulkarni for this. So we are going to discuss few things about bone and joint infections in children, and hopefully I would like to cover the presenting symptoms, discuss what is the best way to diagnose it and what is the most effective strategy to treat it, and discuss some of the complications and long-term sequelae. So let's look at this case. A 13-month-old who is refusing to bear weight on the leg. There is pain, the child is crying with diaper change, child is irritable and having fever since last 2 days. So what is it? So before we go into what is it, we go to some basics. We will be looking into septic arthritis, osteomyelitis acute, which is defined as less than 2 weeks, and pyomyositis, which is abscess formation of the muscle. So all these three